Guys, welcome back to the channel. So we have started with herpes simplex virus SSB1 infection, in which we have dealt with primary herpetic gingivostomatitis. We have dealt with recurrent herpes lesion, and we have dealt with herpes whitlow. We'll be dealing with the treatment plan of those. Okay, let's start today's lecture. Treatment. Topical agents include penciclovir 1% cream, acyclovir 5% cream, and docosanol cream. If used early in the course of treatment, useful in shortening the duration of secondary lesion and reducing the symptoms. Primary herpetic gingivostomatitis is a self-limiting and should require only supportive care consisting of hydration, antipyretics, nutrition, and possibly antibiotics if secondary bacterial infection arises. So, primary herpetic gingivostomatitis is a self-limiting condition. So, it mainly requires supportive care, that is hydration, antibiotics मतलब फीवर के लिए, देन न्यूट्रिशन एंड पॉसिबली एंटीबायोटिक्स. एंटीबायोटिक्स कब देंगे? इफ सेकेंडरी बैक्टीरियल इन्फेक्शन अराइज. नाउ इन सीवियर केसेस देयर वुड बी सिस्टमिक एंटीवायरल थेरेपी. Now, recurrent oral herpes is a self-limiting condition and their course can be endured over 1 week to 10 days. Herpetic multiple debilitating recurrent lesion and or frequent extensive recurrences require acyclovir 200 mg 5 times daily for 10 days at the first sign of new lesion. तो जब न्यू लीजन होगा तो विल गिव एसाइक्लोविर 200 mg. देन वी कैन गिव वेलासाइक्लोविर 1000 mg 3 times daily for 7 days, or we can give famiciclovir 500 mg 3 times daily for 7 days. Okay. Now, continued prophylactic oral antiviral drug therapy is recommended in immunocompromised patient. So, in immunocompromised patient, the continued prophylactic therapy is needed. Coming to the prognosis part, antiviral drugs are effective, particularly if started early in the disease course. Long-term antiviral therapy in the immunocompromised patient is effective and safe. Okay, that's all about herpes simplex virus. Now coming to the herpes zoster virus. Clinical presentation and pathogenesis. It is disease of reactivated latent varicella zoster virus. Older adults are frequently involved and compromise immune status patients. Lesions that are pustular and vesicular form after a short prodrome of pain and itching sensation. तो पहले पेन और इचिंग होगा, उसके बाद वेसिकल्स और पुस्टुला फॉर्म होंगे. The lesion will follow a peripheral nerve distribution precisely and stop abruptly at the midline. So see, this is seen in herpes zoster is like एक कोई भी नर्व पेरिफेरल नर्व डिस्ट्रीब्यूशन को इन्वॉल्व करेगा और अब्रप्टली मिड लाइन में रुक जाएगा, एज सीन इन पैलेट में herpes zoster के इन्फेक्शन दिखेंगे एंड विल स्टॉप इन द मिड लाइन. Now, the lesion will quickly ulcerate and become necrotic with crusting if on skin and may denude bone if on mucosa. अगर स्किन में है तो वो नेक्रोटिक हो जाएंगे विद क्रस्टिंग, और अगर म्यूकोजा में, जैसे ओरल म्यूकोजा में मैंडिबल में दिखता है डिन्यूडेड बोन, तो डिन्यूडेशन ऑफ बोन इफ अकर्स ऑन म्यूकोजा. Okay, pain is usually intense and constant. The dermatomes of the chest wall are the most common site for herpes zoster, but the areas of trigeminal nerve distribution, particularly the ophthalmic division, are the next most common site. So, the most common site for herpes zoster is the dermatomes of chest wall, but after that the concern is trigeminal nerve. So, if trigeminal nerve is involved, obviously the oral mucosa is involved. And in trigeminal nerve also, it involves particularly the ophthalmic division. Okay, that's all for today. We'll be dealing this in the next class. Till then, like, share, subscribe and comment. Bye.